Hello, everyone. This is Dr. Siddarth Tambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today. Before I get started, please note that if you have any questions, please ask in the chat or the questions section, and I'll be sure to pause and respond as we're going along. And if you have any questions after we're done today, you can always email us or call us or connect with us via any of our social sites. And lastly, for those folks who are currently watching live, you'll get a chance to get a replay of this after we're done today. There'll be a recorded copy that'll be sent to you, and you can watch that afterwards or share with anyone else who you think would benefit. Okay, great. So today we are talking about regenerative medicine treatments, and here's a few things you'll learn about. Learn about how to get the best available treatments, non-surgical treatments for arthritis and tendinitis that do not require surgery, using your own cells, what is legitimate and reasonable to expect in the field of regenerative medicine, and how to choose the correct physicians and clinics for your treatment, wherever you are. And again, after we're done, if you ever need to contact us, you can connect through our social media channels or through chicagoarthritis.com. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercises and activities would you restart? And what activities with family and friends would you participate in again? So a little bit about who I am before we get started. So again, name is Siddarth Tambar, physician here at Chicago Arthritis and Regenerative Medicine. Specialize in rheumatology and regenerative medicine, specialist in image-guided musculoskeletal injections. In practice since 2008, in the regenerative medicine field since 2008, and within the Regenix network since 2012. The Regenix network is the largest network of affiliated physicians where we're sharing processes, results, best practices when it comes to regen med. So in terms of my own personal journey into regenerative medicine, when I was younger, I played a lot of tennis and racket sports. Didn't really have any shoulder problems then, but in my medical training, I learned about diagnostic musculoskeletal ultrasound and noticed that I had some chronic rotator cuff issues in the shoulder before I even had pain. And eventually, as I restarted playing some of those sports as an adult in my mid-30s and 40s, I started to develop then some shoulder issues. And that got me thinking about tendon and ligament injuries, different than how it's traditionally been done, meaning realizing that a lot of our traditional options were really not adequate for what people were dealing with, including myself. And the reality is that the traditional care for most musculoskeletal injuries, whether you're talking about tendon issues, arthritis, ligament issues, spine issues, is very much to mask the pain and eventually waiting for just surgery and not really much else. So there's a lot of problems with traditional care. They don't fix the problem for sure. Pain medications, they have a lot of potential side effects. A lot of traditional injections like steroid injections and nerve blocks, they can help with pain, but they do have potential side effects as well that are really not great for you long-term. Surgery, appropriate in some cases for sure, but is frequently overused for things that could be treated with regen med or without surgery. And the problem with that is that surgery is definitely higher risk. It can definitely accelerate the arthritic process if you're just getting like a routine arthroscopy surgery, can lead to more instability. And really, for those of us involved in regenerative medicine, in the same way that medicine for other fields, let's say for cardiac issues, has gone from being big open surgeries to smaller and smaller surgeries, and eventually to needle-based procedures where you're not even doing surgeries. That is the way that musculoskeletal care should be going as well, where you reserve surgery for really the most severe things and everything else is handled non-surgically. So in looking for better options, we want options that are lower risk and avoid side effects. That's key, meaning that you can get similar or better outcomes, but with less side effects. It should address the source of the problem. The source of your problem, if you've got a musculoskeletal issue, generally comes down to one of two things: instability, which is generally what you see for wear and tear arthritis, meaning that there's been some chronic looseness of the ligaments that's developed due to stress and prior injuries, and now there's chronic instability that now leads to arthritis there, or chronic inflammation or metabolic issues. That can be in people who have chronic inflammatory conditions or people who are dealing with chronic metabolic issues, let's say obesity or diabetes, where metabolic or inflammatory issues can also cause pain as well. These are treated differently. The vast majority of things are instability. Some things are also metabolic and inflammation, though. So if you treat the actual cause of the problem, you're likely to get a longer term and better result as well. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. And I apologize, just please hang on one moment. Okay. So regenerative medicine, this is the field of medicine where we utilize your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. So if you think about how the body normally heals after an injury, take something small, such as, let's say, a cut on your finger. What happens is that you have platelets at first enter the area. They stop the bleeding. They then release growth factors. Those growth factors then cause inflammation. They bring in other cells. They also stimulate your local stem cells at that site, which then starts a normal healing process. This takes weeks to months, and this works well if you've got good blood flow in an area. For tissues where there's poor blood flow, let's say tissues like tendon, cartilage, ligaments, discs, labrum, menisci, they tend not to heal as well because they have poor blood flow. So regenerative medicine is a process where we take those same cells, your own platelets and stem cells, and then inject that under high-level imaging guidance into an area that's been damaged to start that normal healing process. So why regenerative medicine? Again, we're treating the source of the problem, instability and inflammation, and we'll discuss more about that as we go along. Safer than surgery, effective for most musculoskeletal conditions. And again, for those of us involved in the field, strongly feel that eventually, like other fields of medicine, this will start to take over more and more of what's been done with traditional big surgeries. So again, how does regenerative medicine work? A few different ways. We're optimizing cells that have been chronically damaged so that they're functioning better, improving the strength and stability of those supporting tissues around a joint, ligaments, tendons, and other soft tissue structures. That's what leads to better stability. This reduces chronic inflammation, and we can also improve some of the muscle and nerve issues around a joint that are also causing pain as well. So this is a really busy slide, but an important one. You know, what makes a musculoskeletal or regenerative medicine expert? And it's a few different things. Number one, your physician should be a musculoskeletal expert. And actually, they should be a physician based on training. But by being a musculoskeletal expert, the key is that they're focused on just that. Your physician should not be treating high blood pressure in one room, should not be treating someone's erectile dysfunction in one room and then coming to treat your knee. They should be focused on just treating musculoskeletal issues. They should be a non-surgical musculoskeletal expert. By that, I mean our surgical colleagues are very well trained in surgery. Some of the things that you need to do these kind of procedures correctly, such as high-level image guidance, they don't necessarily have those skills. That's not part of their training. So with image guidance, your physician should not be just palpating the skin and sort of trying to guesstimate where they need to inject. They should be using the highest level ultrasound and X-ray guidance that's available. The reason why is if you're injecting steroids, it's fat soluble. So, you know, you can inject anywhere and you'll get some benefit. You could inject somebody's ear and they'll get benefit in their toe. But if you're injecting cells like your own platelets or bone marrow cells, now you have to be precise down to the millimeter, sub-millimeter even. And if you're off, you're not going to get the right kind of response. So image guidance is essential here as well. The next one is they should understand how to use inflammation to help you heal. This is important. What I see for some of our pain management colleagues is that they'll offer steroid injections first line, and then if somebody's failing, then they'll talk about regen med. That's the wrong way to think about this. Steroid injections stop inflammation. They stop the normal healing process. And if your physician does not quite understand that they should be offering a regen med treatment up front, then they're probably missing how these treatments really work. They're probably misunderstanding that. And they should understand that different biologic treatments are utilized based on your issue, your medical problem. It should not be a one-size-fits-all problem. If your physician is using the same lab processing for, let's say, a knee as they are for a shoulder, and they don't understand the differences, then they're going to miss optimizing your treatment. They should offer a treatment that is very personalized to your plan. It should not be just a one size, hey, every knee patient that comes in gets this kind of treatment. It should be more nuanced than that, based on your medical problems, your age, and severity of issue. They should be able to alter your treatment plan. I'll show you more about that in a little bit. Prolotherapy is another key thing. I'll talk more about that, but that's key for treating instability. If your physician is only treating, let's say knees. Let's say you come in with knee arthritis pain. If they're only injecting into the knee joint and not all the other structures around the knee, then they're not really understanding how to treat instability and how to get the best results here. They should definitely be transparent regarding your results and your candidacy for treatment. They should understand what makes someone a good, fair, or poor candidate and what that means in terms of actual results and how to get that as well. They should follow your results long term. Your physician should not just be doing a procedure and disappearing. They should be able to follow you through this process as well, and they should guide you through the process. These treatments are newish. They're not new. They've been around for a couple of decades now, but patients have questions, and they should be able to guide you through that process. If your physician is telling you, I think this may help, I'm not sure, they're probably not an expert. They should have more nuance in that. So some other basics and questions that we frequently hear are as follows. Is this legal? Yes, there are strict guidelines from the FDA, including you're using your own cells, not somebody else's cells. Number two, that you're using them the same day that you prep them. You cannot culture them or hold them for prolonged periods of time. And then they should be used for musculoskeletal issues. So if you're using this for, chronic brain injuries, lungs, kidneys, that's not what this is about. That's not allowed by the FDA, and that's not what we're talking about today. Really used strictly for musculoskeletal conditions. Another common question that we hear people say is, if I'm older, shouldn't I use someone else's cells? There's really no evidence that's the right thing. For the vast majority of orthopedic conditions, there's good evidence that using your own living cells is effective. If you hear somebody say, maybe you should use somebody else's cells, they may not be aware of some of the nuances here. For example, they can't use somebody else's living cells in the United States. That's not legal. Or they may be offering you something like amniotic or placental cells where there's not actually any living cells. So there's a lot of nuances to this, and you need to make sure your physician is offering you the right thing. Is there an age limit? Strictly speaking, for the vast majority of things that we do, no. That includes for knees, backs, shoulders, elbows, ankles, neck. Not impacted by age. Hips, hip arthritis specifically can be impacted by age. And so that's the one where if you're over the age of 65, 70, where hip outcomes can be worse if you're older. But everything else does not matter based on your age limit. Granted, it would be great if we were all 25 years old and, had a mild issue and had our own kind of fresh, healthy cells. But regardless, if the goal is pain relief and functional improvement, age does not seem to make a difference for most things. Again, what sort of doctor does these treatments? As I mentioned, proper musculoskeletal expert, proper regenerative medicine expert, which I talked about. Can these treatments help if you've already had surgery? If you've had your knee replaced, we can't treat the knee, all right? But if you've had, let's say, a knee arthroscopy, we can still treat that. If you've had lower back surgery, we can still treat that. But obviously, if you've had surgery, it makes things a little bit more complicated. Things may be a little bit more unstable, or there may be some hardware there that we have to work around. So it depends case by case situation, but frequently we can help people that have already had surgery. My general rules for orthopedic surgeries, if you've been recommended that, is Try to keep your anatomy if you can. Avoid surgeries that are only cutting out tissue and nothing else. That's a lot of arthroscopy surgeries. Always consider a regenerative medicine treatment option if you've already been recommended surgery. See if that's an alternative as well. So we're going to talk about some key topics when it comes to regenerative medicine, and I'll show some cases as well. Stability prolotherapy is our really first key concept. So there's this concept in architecture called tensegrity. And what it means is that if you take individual units that are weak on their own, if you put them in close approximation and compress them, you have an overall structure that's stronger. So in biology or in your musculoskeletal health, that's called biotensegrity. Prolotherapy is the idea of injecting your own cells into the soft tissue structures that surround the joint. And you do that in order to basically strengthen and stabilize the tissue longer term. You treat all the different layers that are affected, and you treat it above and below the joint as well. And what that does is it leads to progressive strengthening over time, and it leads to longer lasting results for you as well. Key, because again, if your physician is treating, let's say, your shoulder, and they're only treating that one structure that looks abnormal, they're not treating everything else that's been pathologic over time, they're missing an opportunity to give you a better result long term. And you get that through that prolotherapy concept. So this is a case study of an individual with lower back issues who'd already had a lumbar laminectomy ×2, still having chronic back pain, failed back surgery, basically. Originally utilizing his own platelets, treating the ligaments, facet joints, muscles, and epidural space, got some early relief. We ended up escalating to bone marrow and did much better longer term. The keys here are, number one, someone's got chronic back pain. You don't just treat the epidural space where the nerves are coming from. You treat all those other structures, the ligaments, the muscles, the joints, and you'll get a better result. The other thing here is understanding that there's different types of cells that we use, and in this individual's case, he did better with his own bone marrow stem cells. Orthobiologics. These are the biologic cells that we inject into your tissue. Again, they utilize that normal healing process. And again, use your own cells, please, not somebody else's. In the United States, you can only legally use your own cells. If they're using something like amniotic or placental cells, it's because those cells are dead. They've been processed in a way that there's no living cells. That's how they can be sold and utilized in the United States. You may hear of other places and other parts of the world where they're using other people's cells. Might be okay. There's very little data on it. I would say use what's been proven and what's being used again and again and again, and what's been shown to be safe and effective in the medical literature. So platelets are really our first line orthobiologic treatment. So platelet-rich plasma, essentially after an injury, platelets recruit other cells. We talked about that, and growth factors to assist in repair. Starts with inflammation, which then leads to tissue repair. So platelets work because they stimulate your local stem cells and bring in other cells that are useful for healing as well. There's different types of platelets. There's platelet-rich plasma. That's where you take a sample of your blood, concentrate into a high concentration of platelets, and inject that. We use that for most things, including for joints, tendons, sometimes ligaments. Then there's platelet lysate. That's where we take those same platelets, crack them open, and just take the growth factors. We'll utilize that for nerves because it's less inflammatory. So the picture on the right, there's two different types of platelet preps there. The one on the right has a high degree of red blood cells. That's more inflammatory. Better for muscles, would not recommend that for joints and tendons. The one on the left is amber colored or yellow colored. We've taken out the red blood cells, so less inflammatory, better option for joints and tendons. If your physician is offering the one on the right with more red blood cells, maybe not the best option for you. Just want to make sure you know what you're getting. Also keep in mind that we can vary the concentration here. If your physician is doing this as sort of a one-size-fits-all, where they take out a couple tubes of blood and then re-inject that after a quick spin down, you're not getting the highest concentration. For some people, if you're older, if you have a chronic issue, if you have more arthritis, using a higher concentration of platelets is key. If you've got more of a ligament or tendon issue, you're probably using a little bit lower concentration of platelets. Your physician should be able to vary that dose and concentration. Most places cannot. Understand that. Because of that, you're not going to get the ideal outcome if you're getting a one-size-fits-all treatment rather than that kind of subjectivity and personalization and adjusting your cell count based on what your issue is. That's actually a bigger deal than most people realize. So it's a case study of an individual with knee tendinitis, referred to me by his sports medicine doc. He's a regular guy. He happens to cycle a lot, and he had a lot of pain in his knee. Turns out, based on MRI and ultrasound, he's got patellar tendinitis. Picture on the right is an ultrasound image, and what we see is a normal tendon, and then as you get to the bone, which is the white structure on the left side, you see a lot of tendinitis findings. So in his case, we ended up doing PRP treatment. We ended up treating his knee patellar tendon twice, and he's done great. The picture on the right is, again, that same tendon, and you see now this long structure. That is the needle is zoomed in. It's not that big in real life. That's just what it is zoomed in. Injecting platelets directly into the area that's been injured and damaged. The key here is being very precise in our targeting with the right kind of treatment option in the right kind of patient. So he did great with treatment. 3 years later, I saw him his other leg now. He had a tendinitis issue in his hamstring tendon. Again, treated with platelets, pain resolved, back to activity. Really good result in someone with just using platelets. The next orthobiologic to be aware of are stem cells. So again, stem cells are the main tissue that drives tissue repair. Please use your own cells, not somebody else's. That is what is state-of-the-art, tested, proven. That's what's appropriate. In the United States, you can really only utilize a stem cell treatment from your own bone marrow. All right. Fat cells, there's a way to isolate stem cells, but it utilizes an enzyme that the FDA thinks may not be safe in humans. So you may see fat stem cells used in other parts of the world. That's called stromal vascular fraction, SVF. That is not legal in the US. You can use fat or adipose for structural issues. Let's say you have a tendon tear or ligament tear. You can still use fat in those cases, but that is different than really isolating it as a stem cell treatment. Again, you may hear about amniotic or umbilical cord cells. To give you a little bit of perspective of how those cells are processed, after birth, the mother has the option of sending that to a facility that processes these kind of cells for then medical use. When it comes to that facility, they first pulverize it, gamma radiate it, make that into a powdered form. That powdered form has no living cells in it. That's been tested by multiple organizations, third-party organizations. That then gets put into a glass vial, shipped to the doctor's office. It can sit there for up to 2 years. When it needs to be used, they're basically taking sterile water, putting that in to rehydrate it. By the time that's happened, there's no living cells. There's a lot of debris. There's some growth factors. It can help, but realize that you can just use your own platelets and get growth factors. Why utilize something like someone else's cells where there's not as much evidence of its utility? IV stem cells, again, something you may hear in other parts of the world. Really no proven benefit for orthopedic conditions. May help with generalized inflammation, but again, very little studies on its efficacy. I would be cautious. Understand that in a lot of places, not a lot, I mean, in the places where they're doing this overseas, they may be injecting placental cord cells. You just have to be cautious about potential issues, clotting issues, that rejection issues that are really not well studied. In terms of outcomes, here's what you can expect. We have a lot of people that come that have had very chronic issues. And, we can still help people with their pain and function. If your goals are, can we improve your pain and function by 70% or more, still possible if you have even an advanced case. Can we actually improve your X-ray and MRI images? If you've had advanced arthritis, I can't get your X-ray to look like what it was 20 years ago. There's just nothing that can do that. If you've got a tendon tear or a ligament tear that's less than 2 centimeters, we can still get that to look close to normal after treatment on MRI or ultrasound. If you have swelling in a joint, yeah, we can absolutely still improve that long term by reducing inflammation. If you have changes in the bone, avascular necrosis or bone marrow edema, we can actually improve that as well if we're catching it at the right stage as well. Some things can get too advanced and you can't necessarily do that, but can still help with pain in those cases. So here's a question. Can we treat bone-on-bone arthritis? This term bone-on-bone is a very bad term that physicians kind of sometimes use because it doesn't really explain what's going on. The reality is that if you've got advanced arthritis, let's say in a knee, and you can still move it through your range of motion, it's not really bone-on-bone. It's just you've got advanced arthritis. So yes, we can still treat that. Depends on the issue, but yes, we can still treat that. Arthritis is a biologic condition, treatable with orthobiologic treatments. If your range of motion and function are still fairly good and intact, you can still get a very good result from treatment. Caveats to this are, number one, if you've got advanced hip osteoarthritis, much more challenging, we generally will refer those for surgery. Expectations, if you've got more advanced arthritis outside of the hip, let's say knee arthritis, back, shoulder, is that we can still help with your pain and function. Probably will not be able to reverse your chronic imaging findings though. But if your goals are to feel better, function better, we can still help with that. So can we help if you've got tendon and ligament tears? If you've got a partial tear, absolutely. We're going to talk about full thickness tears because that's interesting. So imagine if you have a tendon. Partial tear would be if you have a little bit taken out. Full thickness tear would mean that there's kind of a cut all the way through. If it's still closely approximated, we can still treat those. If you have a tear where it's pulled apart, where it's like centimeters apart, more than 2 centimeters apart, that needs surgery. Post-surgery, you should think about getting your own bone marrow cells re-injected. So this is a case of a 20-year-old man. He's a butcher. He had an ACL tear while playing recreational volleyball. I saw him a couple of months after treatment. We ended up using his own bone marrow, concentrate stem cells, injected into the ACL. At the 3-month mark, no pain, restarting dynamic activity with physical therapy. I'll show some images, which is kind of exciting to show what can actually happen. This picture on the right is an X-ray image of the knee. There's a kneecap, thigh bone, shin bone. This long, straight structure here, linear structure, that's the needle. This is under X-ray guidance. And what's in the middle is the ACL. To inject the ACL, you can only do that under high-level X-ray guidance, reliably. All right, you can sometimes get lucky if you're doing it with ultrasound or blindly, but to do it reliably, it's under X-ray guidance. So what's exciting in his case is not only his clinical result in terms of pain and functional improvement, it's his imaging result here as well. So the MRI image on the left, I don't think you can see my cursor, but essentially what you see is a knee MRI, and in the middle, you have an ACL that's very hazy, very blurred. The radiologist has read this out as either a complex tear or a full thickness tear. Now, it's not fully retracted. The edges are still closely approximated. The MRI on the right, which is why we proceeded with treatment, the MRI on the right shows now an ACL that's now been read out as normal. There's still a little bit of fluid around it, but this is 3 months out. ACL looks normal now. And this is a great result because he's not only doing great from like a clinical standpoint, his MRI is pretty exciting as well. Okay, I'm not sure for some reason part of that slide did not load, but the next is, I know why, this is a shoulder case. Let's see. Right, so this is a shoulder case, and this is a nice one. This is a 57-year-old man. He's a general contractor, does a lot of overhead activity. So he's developed some chronic shoulder issues. When I first saw him, he was having a lot of pain, was not able to work. The ultrasound image is on the left, above and below. This is his ultrasound. There's a hole in the middle. That is a full thickness tear of his tendon. We use his own bone marrow stem cells and PRP, and these are his images. He's doing great clinically. Now, 3 months later, where you previously saw that big hole in the middle, you now have that filled in. He's got that healing process going. Clinically, we are now, I think, 7 years out. We ended up doing a booster PRP treatment for him, I think the end of last year, and still doing great. Shoulder tendon still looks good. Great example of not only great clinical result, but also great imaging result as well. Next step to understand is interventional orthopedics. This is the process where we use image guidance to inject your own cells. So we've shown some pictures, and the pictures here are for the shoulder. Again, when you're injecting cells, you can't be close. You have to be precise, sub-millimeter level. These are zoomed in images. So the picture on the left, it's of a rotator cuff tendon that's being injected. It's a very small kind of black hole area right there, very small. That is less than 1 millimeter. And you see the needle coming in, injecting very precisely into that area. Picture on the right, it's again the shoulder, injecting into the shoulder joint. You see the needle. You see a curve kind of line here. That's how we know we're injecting into the joint. There's a little triangular structure right there. That is the labrum. Again, to inject the labrum, have to do it under high-level X-ray guidance, and that's how people get better results. I showed these images before. The one on the left is injecting patellar tendon. The one on the right is injecting to an ACL. One we're using ultrasound, one we're using X-ray. Use the right tools for the right job. That's how you get a better result. In some cases, we'll be using ultrasound and X-ray at the same time. This is a case study of an ankle avascular necrosis patient. This is a 41-year-old man. He's a chef on his feet for 12, 13 hours per day. Came to me with ankle pain. His image on the left, his MRI image, shows not only that he's got wear and tear arthritis, he's got fluid in the joint, he's also got what's lighting up in the bone called avascular necrosis. All right. If we don't do anything with that, that is essentially bone that's dying off. If we don't treat that, the joint above it, the cartilage, will start to die off as well. So we end up using his own bone marrow cells. 3 months later, doing well. He's actually a few years out now and doing really well, working and all that. His image is on the right, 3 months after. You see the fluid in the joint is gone. You see the swelling in the bone is gone as well. So clinically doing well, and we've actually stopped in its tracks the actual process that's driving this as well. So great result. Regenerative medicine treatments offer safe and effective solutions for your pain. Just checking to see if there's any questions on any of our social sites where we're streaming live as well. And again, if you have any questions after we're done, please go to chicagoarthritis.com. And again, please enter any other questions as we're talking into chat as well. So is this too good to be true? It's always a good question. So I have colleagues who say, orthopedic colleagues who maybe 10 years ago would say they thought these treatments didn't work. 5 years ago, they said they're still not sure. And now they'll say they're not sure, but they'll offer it. The reality is that there's evidence that goes back to the mid-90s. Philip Hernigue, French orthopedic surgeon, has been treating shoulders and knees with bone marrow and comparing it to his patients that had surgery. All right. He finds very comparable results without surgery. Regenix Network has been doing this and collecting data since 2005. I know colleagues in this country that have been doing this since the year 2000. My own personal experience starts in 2008. Yes, this is a developing field, but it's not new. There's right and wrong ways to do things. Your expectations should be grounded in reality and evidence-based medicine. You should be working with physicians who are experienced and know what they're doing as well. How long do results last? You know, there's data that goes out 10, 20 years now. What I tell people, however, is that if you have a chronic condition, think conservatively. Expect that you'll need a repeat treatment at some point, a few years after initial treatment. So let's say you have mild to moderate knee arthritis. Expect that if you get PRP treatment, expect that you'll need a repeat treatment in the next 2 to 3 years. On the other hand, if you have, let's say, moderate to more advanced knee arthritis, if you get bone marrow stem cell treatment, that'll probably help you for the next 5 years. You may need a booster treatment of platelets at some point. That may be after a couple of years. And then after 5 years, you may need to repeat bone marrow treatment at that point. So those are realistic expectations. The best way to maintain your results long-term would be improve your biomechanics, strengthening the right things, range of motion exercises, work with physical therapy, use the appropriate joint supplements. Repeat treatment can be additive to the initial treatment. Maintain ideal body weight for a couple of reasons. Number one, every pound of extra weight that you have basically adds 4 extra pounds of pressure on your lower extremity. So reducing weight, if you need to, will reduce stress on the lower back and legs. If it improves your metabolic health, we know that poor metabolic health is connected with inflammation, which is connected with pain as well. And so, we're focused on weight loss as well to help people get their musculoskeletal goals as well. Some cost issues to be aware of. This is not routinely covered by insurance. Regenix does, however, have relationships with about 3,500 self-employed companies in this country. If you go to regenixcorporate.com, in which case it is covered by insurance, that is probably how this is going to grow, through employee insurance. Cost estimate, if you're paying out of pocket, are listed there as well. For prolotherapy, expect $750. For PRP, $2,500 or up, and stem cell cost is $7,000 and up. Keys to determine value are the following. Is your physician and the clinic, are they regenerative medicine experts? That long list that I had, they need to have all that. Are you receiving a real stem cell treatment or something that's mislabeled? Again, make sure you're getting something that's properly vetted and real. And then understand that these are in-office procedures for the most part. You can avoid expensive hospital and surgery center facility fees. Healthcare in America is very complicated in terms of payment and insurance. And if you're getting things done at hospital and surgery centers, you'll automatically get a facility fee attached to that will increase your price by 50% to 100%. And most of these procedures do not need to be done in that setting. They can be done in an outpatient setting if your physician is doing things properly. Mentioned before, there's a lot of things involved in becoming a regenerative medicine expert that you should be looking for in your physician and clinic that you're choosing to get treatment at. If they're not doing all this, they're not really on the ball, and they should be. Just a little bit more about how we do things here at Chicago Arthritis and Regenerative Medicine. We're focused on non-surgical treatment for your musculoskeletal issues, arthritis, tendinitis, injuries, and back pain. Evaluating for inflammation, instability, any asymmetry issues, neuromuscular issues. Trying to correct that with low-risk interventions if possible. If that's not working, if you've got something that's treatable with the regenerative medicine treatment, we'll then talk about that. Utilizing the highest quality products from yourself, your own body, a plan that's tailored just to your condition and needs, and delivering those cells under precise localization with ultrasound and X-ray guidance. Interested in getting it evaluated, you can go to our website, chicagoarthritis.com. You can email us, you can call us, which is being put into chat section as well. And we are here to help if you have questions or if you'd like to be evaluated. Well, thank you everyone for your time today. We are coming to a conclusion of our webinar today. If you have any other questions, please let me know. And again, if we can be of any additional assistance now or later, please contact us at your convenience. Looks like I've already cleared off all the questions. And thank you everyone for your time today. Happy New Year. Hope everyone stays healthy and is safe and lives well. Bye-bye.